responsible for public health, and more broadly, my title is active health. So the active health of everybody within BCP, and of course in broader Dorset, and also I've got the tourism liaison on the side of that as well. So pleasure to be here, and let's get straight into the agenda. But I think before, in our pre-meeting, and I was very, very pleased to agree with what Councillor Peter Wolf was proposing, is that let's not all be strangers on this. I know maybe some people are sort of here, maybe as stand-ins and so on, but on the other hand, I think the mission that we're on here is couldn't be more serious, couldn't be more worthy, and let's not be strangers as we embark on this going forward. So with your permission, everybody, could we, I'll start and ask my Peter to introduce, and I'll go last. And I'll, as I should, and talk a bit about myself. But Peter, and then forgive me if I go in a sort of what is a random order around as I see people's faces on the screen. But Peter, just a bit of intro from you, and just say like one line about what your kind of ambition is going forward for this group. And please, everybody, let's take a bit of time on this because I think it is quite important. And I hope that, when we've done it by the end, you'll agree it was worthwhile. So, Peter, just a little bit from you, please.
Before we kick off, Mohan, could I just formally suggest that we elect a chairman and propose yourself to chair this meeting?
Let's take the item first then. Okay.
Thank you.
I'll hand over to you, David, for this part.
Thank you. The first item on our agenda today is the election of chairman. It is a representative of Bournemouth, Christchurch and Poole Council. So may I have nominations for chairman, please?
I propose Mohan Iyengar to be chair.
I'm happy to second that.
Thank you very much. I have a proposer and seconder. Any further nominations? Thank you. On that basis, Councillor, you are elected chairman, and we'll take things from there.
Okay, so then in which case let's go to item 2, which is the appointment of vice chair. I'd like to propose, please, Councillor Peter Wolf as vice chair of the committee, and may I have a seconder? We're asking for seconders here. May I have a seconder with that?
I'm happy to second if you haven't got anyone else.
Okay. Thank you, Councillor Carl Jones there. And
sorry to hijack your meeting there, Mohan, and about without doing the introductions, but I know David's a stickler for process. You know, we must obey our officers.
We've achieved all that's necessary. We can proceed.
Absolutely. Okay then. So fine. I need to ask is, forgive me, were there any other nominations for vice chair? I have done this before, believe it or not, despite how it sounds. Okay, thank you. Let's go ahead then. Anyway, delighted to be chair, and Peter, absolutely great got you as vice chair. Okay, now, just David, are we okay to do the introductions? Let me just check. Is there any other administrative things up front?
No, we'll do that now.
Wonderful. Okay, Councillor Peter Wolf, please just do kick off and say a few things. Good.
Mohan, thank you very much for that very generous introduction. As you said, we had a pre-meet and we ended up in violent agreement on just so many things. It was ridiculous. So that's really good news, and it augurs well for the future. I have two. I've got a number of things, but I've got two things that are quite top of my pile. The first is I want to support Sam because I think he's been placed in an unbelievably difficult position, and he deserves our support because he's battled valiantly throughout the pandemic and been remarkably cool under fire. And the tailwind of the pandemic could well be just as difficult whilst people try to address the pandemic and come out of it at the same time. So that's my first thing. But my second thing is I'm very keen that we work to try and ensure that the various committees that we have don't get in each other's way and do work well together. And it's a point I've made to Sam and to Mohan separately, because we've got a number of committees, including the new Integrated Care Board, this particular committee, the Health and Wellbeing Boards. And I'm not entirely comfortable that there is a clear understanding as to each committee's remit and where they work with other committees. And I worry, and if I liken this to a game of doubles tennis, I worry that there will be occasions when the two players on the same side will go for the same ball and crash rackets. And I worry that there'll be occasions where both players look at each other and say yours, and it goes down the middle. So I'm looking for some clearer understanding of how the committees work together and how they make sure that there's no clash. And my reason for that is that we'll all achieve a lot more in terms of public health for Dorset if that is clear. Thank you, Mohan.
Great. Thanks very much, Peter. Let's go around at a good clip. Graham, can I come to you next? Graham Carr-Jones.
You can. Thank you. I'm Graham Carr-Jones. I'm probably I think I'm the last surviving member of the former membership of this committee, and I am the housing and community safety portfolio holder for Dorset Council. I almost echo what Peter said about Sam Crowe, other than he's poached yet another one of our really great officers into public health. But wishing everyone all the best. Thanks, Mohan.
Okay, lovely. Thanks a lot, Graham. Karen, can we go over to you? Karen Rampton.
Yeah. Hi, thanks, Mohan. Yeah, I'm Karen Rampton, and portfolio has slightly changed. We had a little mini reshuffle, and I am now People and Homes at BCP. Kind of echoing Peter, really, in terms of ambition for the group. I think it's really important with the formation of the ICS from next year that public health, its place is recognised, and that we are all supportive of making sure that the voice of this board is heard throughout the system. And I'm not sure that's always happened. So that would be my ambition.
Okay, thanks very much indeed, Karen. How about can we come to Jane Somper, please?
Can you hear me?
Yes, we can.
Sorry, here in rural North, connection can be challenging. My role here is also, I'm very, very new to this role, along with Peter as a lead member. We had a mini reshuffle too. So my role really here is just to be supportive to Peter and Graham as well in their roles, and to observe and chip in where I feel appropriate.
Okay. Thanks very much indeed, Jane. We come to Sam Crowe. Go ahead.
Thank you, Chair. Good morning, everybody. I'm Sam Crowe. I'm the Director of Public Health, and it's a shared director responsibility across Dorset and BCP councils. Okay. And anything you could summarise as a one-liner, Sam, about what your kind of ambition for this board is going forward? So in the same way Peter said something, and I totally agree with it, about the sort of the clarity about what we can do, what the others do, and how we really work together as best we can. But I don't want to lead you, obviously, but is there anything particularly you want to put a flag in the ground about something? I was actually going to touch on this in the presentation in the board today, but I think I'll just echo the sentiment that if we're not careful, the system landscape can be quite confusing. So what's really important is that the Joint Public Health Board is comfortable with its role and remit, and that we, from my perspective, we stay in that lane. But Karen's absolutely right. The opportunity with the integrated care system coming on stream is absolutely huge in terms of that wider influencing piece. I think it's just important about understanding how we do that so that we don't mix up the business between different boards. And that's the skill. So that sort of separation between the leadership piece and the influencing piece from monitoring and assurance of delivery of public health programmes and services, because that's really the business of the Joint Public Health Board. But it doesn't mean that it shouldn't have a strong voice. And there's plenty of other places where that voice can be heard, including both health and wellbeing boards, the integrated care partnership, and how the integrated care partnership strategy then influences the integrated care board. So there's lots to do, and I'll touch on that more when we get into the presentation. Yeah. Thank you, Sam. I think that this is a thing that is going to be a very big thing for us going forward, which is it is a lot of work, but equally there's something there about like seeing through and making this as clear as possible to everybody so that we're all working productively. So we'll come back to this, I'm sure. Right, I'm probably now going to sort of, at the risk of offending people, go into sort of an order in which the people are appearing on the side panel here, and apologies, for going in a strange order here. I've got to Andrew Bellini. Andrew?
Yes, hello there. First time at this meeting. My name's Andrew Billany. I'm the Corporate Director for Housing and Community Safety, so mirror Graham's portfolio, and I'm glad to be here. And very briefly, I'm very keen, but partly the echoing points Peter started to make, I'm very keen to join up the dots around this work. I've got a particular interest in public health related issues around housing, when we went to weave some of those issues into the conversation. Good housing or bad housing is at the core of a lot of the issues that we trying to address through this kind of board. So glad to be here, glad to be part of it.
Okay, excellent. Welcome, Andrew. Thank you very much indeed. And I think you may be taking top marks for the backdrop there, Andrew. So the competition is very fiercely on, clearly, isn't it? Okay. Claire White. Claire, I know you're BCP. Just say a quick hi, Claire. Hello.
Hi, I'm actually Dorset Council, so I work in accounts.
Forgive me. There we go. Another mistake from the chair. Okay.
Very common name. So I work in accountancy in Dorset Council, overseeing finance of the public health grant. So I'm here to observe and learn more today.
Okay, excellent. Welcome, Claire. Thank you very much. And we've done Graham and Jane and Peter and Karen. Darren Richardson, please. Darren. Okay, then. All right. Thank you so much, Darren. People like you end up being the most critical people in the meeting, by the way. So there we go. So please don't leave us, okay? David, we know. So David, does everybody know you? Of course, we've met. I think you're probably known to everybody, but please just double check that.
Thank you. David Northover worked for Dorset Council, and prior to that, Dorset County Council. I've clerked various incarnations of Joint Public Health Board over the last 6-7 years. So I feel I've got a pretty good understanding of what things are. I'm very supportive of what we're trying to do and how we're trying to do it.
Okay. All right. Thank you very much. And come to you, Jane Horn, please.
Hi, yes, I'm Jane Horn. I'm one of the consultants in public health in Sam's team, and I'm here because I've helped contribute to the finance paper, which is covering not just the shared service budget, so not just the budget for Public Health Dorset, but also some of the discussion about how the retained elements are used in each local authority.
Okay, good. Thank you very much and welcome, Jane. Okay. Lucy, please. Lucy Mears.
Hi there. I'm Lucy Mears. I'm Communications Manager for Public Health Dorset. So we work across both council areas, leading on any public health related comms and media relations. So I'm here really just to support with that, take away any comms actions today.
Okay, then. Okay, absolutely essential, isn't it? All of that. Thank you very much indeed. Let me see. Pamela, please. Pamela Shea.
Morning, everyone. I'm Pamela Shea. I'm the Deputy Director for Nursing and Quality at Dorset CCG. So I'm here on behalf of Vanessa Reid, who's the Director of Nursing. First time at the meeting, Mohan. So I suppose my own observations around public health is obviously that those determinants around public health often impact on the health and well-being of people. So from a health perspective, in its purest sense, we often deal with people who are suffering from ill health. So I think there's something about joining up that and seeing people in the wider context of how those determinants can impact on people with ill health and potentially prevent ill health. Thank you.
Okay, thank you very much and very, very, very welcome, Pam. Okay, good. And Phil, hello, Phil Hornsby. Hi, Phil.
Good morning, everyone. I'm Phil Hornsby. I'm the Director of Commissioning for People for BCP Council. That includes drug and alcohol commissioning. And my both reflections, but also wish would be that we have a strong focus on early help and prevention, so that we try to get in front of issues around ill health. Excuse me, very inopportune phone call. And the other thing is, of course, the reducing harm through substance misuse, and I lead that as part of the community safety within BCP as well.
Okay, just going forward, Phil, any sort of statement about what you'd like an ambition for this board, just like some of the others have done?
Yeah, well, yes, indeed, and that ambition is around that early help and prevention piece. Mohan, is to really say that we can get in front of the issues that affect people, whether it's in housing, as has always been touched on, but how do we work in the community and tackle health inequalities and just get in front of all the issues, because we often react to issues rather than proactively prevent them.
Sure. Okay. Thanks very much, Phil. Okay. Sam, we've heard from Sarah Longdon, please. Sarah, welcome.
Hi, good morning, everybody. I'm Sarah Longdon. I'm the Head of Service Planning in Public Health Dorset, working with Sam and the management team. One of my key responsibilities is to develop the business plan for the next financial year. And I think the priorities and objectives will be very much set by this board. So listening in to see how we're starting off with that as we go into the winter. Good.
Okay, thank you very much indeed, Sarah. Good. And Sophia, apologies, I hope I got the right pronunciation. Sophia Callahan.
Hello, I'm Sophia, or Sophia, I don't mind. Okay. I'm one of the consultants in public health. I oversee the contracts and commissioning for the public health programmes, and I'm here as health improvement lead.
Okay. Just making a note of that. Lead. Thank you very much, Sophia. Okay, and we've got nearly there, but I hope this is useful for people. Steve Gorson. Steve, welcome.
Thank you. Yep, I'm Steve Gorson. I work for Dorset Council in finance for the adults, housing and public health. And I'm here deputising for Sian White, who's unfortunately not well. So I will be presenting the finance report later.
Okay, thanks very much, Steve. Very important. Thank you so much. And last but certainly not least, Vicky Fern, we've got on the call.
Hi, good morning. I'm Vicky Fern. I'm another one of the consultants in public health, and I'm here to observe today.
Okay. Very, very warm welcome to you, Vicky. Okay, so we've got a good, okay, and yes, I've just got a note there from David. I think just let's deal with that one right first of all. Let me just come to the chat. Let's get that right. Just bear with me 1 second. Just with the change of regime that we've got, of course, then David's very kindly reminded me that we should put on record our thanks to councillors Nicola Green, Laura Miller, for their past contribution to this board and for moving things forward and so on. So that's pleased that that's put on the record. Okay, excellent. All right, so thank you everybody for that. I know we've taken sort of nearly 20 minutes on that, but this is a big board out of necessity. It will involve a lot of people for very good reasons. And just again, you know, I think both from Peter and I most certainly, and others, is that you know, let's not be strangers doing this. Because we're going to have hard enough challenges moving forward. Let's not compound it and make it harder by not even knowing each other. So if that's helped a little bit, it's certainly helped me, I've got to say, just to know who's in the room, where do they fit possibly in the picture, where's their best contribution going to be. I think that's been helpful in breaking the ice. So thank you very much indeed. Okay, let's carry on with the agenda then, please. And let's belt through. So let's key this up. Just 1 moment. Okay, so we've done election of chair, item 2, appointment of vice chair. Item 3, apologies. David, any apologies, please?
Chairman, no apologies from elected members, but as we probably heard, Vanessa Reid is unable to make it today. There is her deputy here, and unfortunately, Sian White is unable to attend, but it's her representative. I think it's Stephen Gorson. Will be doing the finance paper. That's right. Okay. That's all I have.
Okay.
Chairman, I do apologise for butting in. My other lead member, Councillor Cherry Brooks, has just appeared. Would you mind terribly if I asked you to give her 1 minute to do her introduction, please?
Oh, of course, actually. Sorry, yes. Cherry, we've met before. Welcome.
We have. Thank you, Mohan.
The Sandbanks Ferry of all things. But anyway, yeah. Please, Cherry, I don't know if you heard all of us have just given about, when I say a minute, it's just literally to just quickly, you know, who you are, just, you know, please, you may know people, but let's assume that some of us don't know you. And just literally, if you had to say a line, you know, what's your ambition going forward for this board about what we've got to be doing, just in a sort of a strap line. So do go ahead.
Okay. So I'm Councillor Cherry Brooks. I'm the ward member for South East Purbeck, and I am the lead member along with Jane Somper, supporting Councillor Peter Wolf in his portfolio for adult social care and health. It's taken me a long time to get my head around that that title. And a strapline would be that we were all travelling in the same direction with no baggage and making an impact.
Oh, I think you might have won the prize there, by the way. Okay. Okay, all the same time, same direction, best impact. Okay, fine. Wow. Okay, some nice themes coming out. Thank you very much. Welcome, Sherry. Welcome. Okay. All right. So we've done item 3 with the apologies. So let me just hop back here. So coming to item 4 then, declarations of interest. Are there any declarations of interest, please? I'll take that as none. Is that okay? All right, so hopping on then to item 5 then, confirming the minutes of the meeting held on 15th of July 2021. Of course, with membership changing, I wasn't here, so I can't vouch for them. So are there any comments, please, about the minutes from July 21? And what I'll do is we won't go through page by page, let's just take it in totality. Are there any comments at all? Otherwise, going once, going twice, can we sign off those minutes, everybody? I'm not seeing any hands. So, David, I don't quite know how we do this, but I think they're taken as read, those minutes.
That's my understanding and confirmed. We can arrange outside this meeting for some sort of digital confirmation from yourself, and we'll take things from there.
Very good. Okay, thank you, David. Okay, hopping on. So item 6 then, public participation. To receive questions or statements on the business of the committee from town and parish councils and members of the public. So again, David, please, have we received any of those, please?
None received, Chairman.
Okay, thank you. That's covered that item off then. So going to then item 7 then, we've got the forward plan to receive and consider the board's forward plan. So can I just check, is it Sam, am I handing over to you for this item, please?
Thank you, Chair. I was just going to make a couple of comments reflecting some of the set of meetings that we've had with both yourself and Councillor Peter Wolf. You'll note that the forward plan is sort of somewhat deliberately light. So if you're looking forward into the February 2022 meeting, we've got our standard suite of reports that we would normally take through the board. We always take a finance report. We always take a monitoring report of some kind. We usually report back on the progress being made against the business plan. But there is some to now start to pick up some of the issues that we've already heard about in the board this morning. So I know from discussions that we've had, I think an item on the February agenda about the integrated care system changes and how those new boards will work across the system. That would be helpful to have the board's view on the establishment of those boards, but more importantly, how do we think the Joint Public Health Board will influence through that new landscape? And then I've also noted Peter Wolf's comments, which it would be good to have some development time as a board to think through how we populate the forward plan a bit further in advance. So make sure that we've got a proper agenda of work going forward. And one of the ideas that's already been floated is perhaps spending a little bit more time on some of the key public health services. So a bit of a rolling induction, if you like, as to what are some of the major public health services that we commission from the grant. Perhaps moving on then to exploring some of those opportunities to influence the wider system that we've already heard about. So the links, not just between public health and behaviours, but perhaps looking at the opportunities to improve some of the social determinants, the impact of housing. It's important that we've got a clear picture of what we want to say and how we're going to do that influencing through the different boards across the system. So I think I propose in February we'd have a bit of time on the ICS, but maybe also spend a bit of time with members coming back to the board for ideas about how to populate the rest of the forward plan, if that's acceptable.
Okay. Thank you very much indeed, Sam. Actually, at this point, Peter, just also from our pre-meeting, can I invite you to comment as well, Peter, on this about populating the forward plan? I think we had a very good chat on this, and just can I ask you to come in at this point and give your view?
Yes, I mean, this just sounds like I'm agreeing, but I'm violently agreeing, because I think in order to be productive, as you said, we need to understand what it is we do, what it is we don't do, and how we work with the individual councils, with SAM and with the Integrated Care Board. So I think we need some understanding of what it is we should do and what we shouldn't do, and how we're going to do it to maximum effectiveness. And I think that's what we three have discussed in our bipartite meetings, if I can say that. So I think we do need some. I think I said to you, Sam, we need a diagram that shows the various committees, how they link in with each other, what their responsibilities are, and what information they might pass to another one, what information they might share with another, all that sort of thing. Because at the moment, partly it's my fault because I'm new to this, but partly, you know, my business training tells me that this is not entirely clear.
Okay. Okay, good. Thank you, Peter. Let me open the floor up, please. Any other comments at this point on the forward plan? Mindful, it's very much a work in progress, but any comments at all, please? And if you raise your hand or wave something, I'll see you. Not seeing any hands, unless I'm mistaken. Excuse me. Jane, please. Jane Hall.
Yes, I was just going to say, you know, part of the reason why it's not clear is because things are in transition. So I think it may be something that we have to kind of keep repeating as things do become clearer for everybody. So I think, you know, it's maybe not just a one-off thing. It will be something that we need to kind of look at and repeat as things become clearer.
Okay, thank you, Jane. All right. I'm not seeing any other hands. What I'd just add is just really repeating, just adding to what Sam and Peter have just said, is that as well as the clarity around all of it, which sometimes means not so much building the whole thing up, but actually sort of, you know, clarifying it, be able to see through things. Also, this is I will be banging the drum about us looking further ahead. And forgive me, I think either Sam or Peter has already said that. Is that we look at almost, if we can, a rolling year or even 2 years ahead. And actually, I put it this as actually, can we almost start prescribing the agendas for future board meetings? And I don't mean in detail. It's more like the spirit of what I'm saying, really, which is, say, literally rolling ahead. So we don't go from meeting to meeting. We're actually thinking, how do we turn around this sort of super tanker? But actually we do it by taking a view constantly around 2 or 3 years ahead, and more learned people around the table will probably inform us as to what the right horizon is that we should be taking for a board like this. But actually we do keep that sort of long sight, and then our meetings are a means to an end towards delivering that. And I'm very, very keen that that happens. I don't know about you lot, but I'm in too many meetings which exist from meeting to meeting and so on, and one can't help but be operational if one does that. Okay, thank you very much indeed. If there's no other comments then, is that all right? You know, we've not done it justice, the forward plan in that discussion, but it's something very, very much in the works, and our full support to that piece of work. Okay, let's go on to item 8, please, then, the finance report. So I think, Steve, are you leading this one for us, please?
I am indeed, Chair. So if you bear with me, I will just hopefully share the correct screen. Okay, hopefully everybody can see a slide with the forecast outturn for 21-22.
Can you zoom in and make it bigger at all, please?
I'm on presentation mode.
Yeah, if it's not, it's okay then. Yeah.
I will try a quick button and see what happens. Oh, is that better, or is that cut things
Just
off for people?
Go back down one. That's okay, good. Right. I think that's probably what the best we'll get.
Sorry, I say I'll be able to talk through the important figures, and the paper is out in the pack. So hopefully you can we'll all be able to see the forecast underspend for the year 21-22 is a 517,000 underspend against the grant for a variety of reasons. One is that most of the activity-based services continue to see activity levels below the 19-20 levels, which is driving the underspend. There's also been a reduction to a lot of the team costs due to a greater understanding of the additional interim costs set against the COMP fund, which is the Contained Outbreak Management Fund relating to COVID. There is also continued minimal spend on NHS health checks this year, as these remain paused under a national review. Actually, the forecast may change depending on that review. So those are the reasons really driving the underspend. Other things included within the forecasts have been updated for the long-acting contraception, the supervised consumption and needle exchange, and the smoking cessation based on the latest activity. And the other thing to note within this is there have no plans have been agreed for kickstarting the community health improvement services post-COVID, using the 340,000 of reserves, which was previously agreed.
Okay, I'll just hold you there for a second, Steve. I've got Peter's hand up. Peter, do you want to come in now? Yeah.
Oh, sorry, Mohan. It's my unmute is taking forever. Yeah, I don't wish to. This is not a catch you out question. I was talking to Leslie Hutchinson, the commissioning corporate director for Dorset Council this morning, and she said there was a new element stuck in this, which has only just come out, which is a grant for potentially adult social care for both councils for pandemic-y type related things. Are you aware of that? Is that in the budget, or is it something you're not aware of?
I am aware. That's an excellent question. That is going to be on slide 2, which I will come to. So you are ahead of the game as always.
I'm really sorry. Sorry about that.
Not a problem.
Okay, it's all right. Actually, yeah, and just bear with me, everybody, because sometimes I think when questions come, you might find, I think it's sometimes good to take questions as they come in. And at the risk, I know we sort of go in fits and starts a little bit, and then you may have come to the answer shortly. I think sometimes it helps a meeting if we can take questions, and if it's off subject, I will sort of shut the person up, sort of thing, and move it to later. But thank you, Steve, if you're coming to that. I think we had another hand up. I've forgotten whose it was, but it's gone down since. Anyway, Steve, do carry on.
That's the forecast. Says people are hopefully where there are retained elements within BCP and within Dorset. Within the BCP area, the retained element is just over 8 million. Largely just under 5 million for the drug and alcohol services, which covers the whole of the service for the BCP area, and the children's services of 2.5 million for the children's centres and other work, and then some other amounts, including the additional amount that Councillor Wharf just referred to, which I will address at the end of this slide. Within the Dorset area, a much smaller retained amount of just over 1.1 million. And as you'll see, that's 333,000 for the community development, working within the customer services team, the community safety within adults housing of 170,000, and the children's early intervention of 114,000. Again, the Dorset Council area has 500,000 for sort of new additional recurrent funding. And there have been helpful discussions within the adult services team with the colleagues to gain the clarity to what services will fit within this grant, and we're exploring the best ways to use this grant funding to maximise the benefit for Dorset residents. So that is progressing. So hopefully that addresses your question, Councillor Wharf.
Is that all right, Peter? Has that covered it?
Yes, it has. Thank you.
Okay, thank you. Yeah, carry on, Steve. Yeah.
Thank you. That's it. That is the end of the finance report. So I would just ask the committee to note the finance report, and I will ask this tentatively. But are there any other questions?
Anyone else at all? Okay, all right. So basically, we got Jane. You want to come in, Jane?
Apologies. I was just going to say as well, in discussion with BCP, the element of the additional 500k that they have retained for this year will be used within the children's centre piece. So we've got that clarity now around that piece as well, because the reason why we cover that whole retained grant is that the whole grant is that Sam has to sign off both the shared service budget, but both ring fence grants for each local authority.
Okay, thank you. Sam?
Thanks very much. I was going to make a similar point to Jane, actually, and just for the board's information, this year we've engaged the services of Southwest Audit Partnership, who are going to be doing some independent audit on how the public health grant is used, both within the Public Health Dorset service, but also outside of the service under each council, to make sure that we've got clarity around the reporting lines about how the money's used, and also just a bit of a check and balance that it's being used within the grant criteria. So that's a kind of an additional assurance that when the letter comes out and I'm asked to sign along with both Section 151 officers, we've got that additional evidence to back up that we're aware of how it's being used and that we're comfortable that it's being put against public health objectives. So that audit's been agreed with both teams across both councils, and I think the work is starting over the next couple of weeks. So hopefully we'll be able to feed back on some of the results of that through the board.
Okay, thank you with that. Peter.
Yes, can I ask one question and make one comment? If Simon could go back to the previous slide, if I show this to any of my members, they will say, why is BCP getting so much more than Dorset Council? I am not in any way coming, we're not getting our fair share. I just want to be able to have an answer that I can give to people. That's question one. Question two, which is a bit of a statement, and this is completely unplanned. Sam, we've had some challenges with Southwest Audit Partnership. You may care to talk to me outside of this meeting to ensure that you don't end up with the same challenges. Thank you.
Okay, thanks a lot, Peter. Actually, Sam, on that one about these figures, actually, we talked earlier. Does it lend itself to a quick response, or is it better offline?
No, I think I can give a quick response, because when you see the figures laid out without an understanding perhaps of the history and how the grant is paid into both councils, it can lead to confusion. I think the first point I'd make is that we need to be careful of language. The grant is actually belongs to each council, doesn't belong to public health. So the way it comes in, I'm not sure if this was shown on the slides, but you'll see that each council receives a slightly different allocation at source. So from memory, I think BCP Council are receiving around about 20 million now, and Dorset Council is less than that. That is based on a combination of population need, and also some element of history in how public health services were previously funded in the NHS. So it comes into both councils, and then under our shared agreement, we have a range of criteria that are used to agree what's paid into the Public Health Dorset service. And that's the 25 million budget that Steve's taken us through today. So it does mean that outside of the 25 million, there'll be elements of grant that are left with both councils, and they are indeed different amounts. The key issue is, well, I guess I'll pull out two key issues. The first is the original agreement that set up the service back in 2013. There was an agreement between the three legacy councils that Bournemouth Council would retain a little bit more to invest in its children's centres. Poole Borough retained some money for drug and alcohol services at the time, and Dorset Council gave most of it over into the new shared service. But over time, there's been a bit of drift in and out of those retained amounts, and the position we're in today, BCP Council now commissions the whole of the drug and alcohol service, whereas the year before, Public Health Dorset commissioned the prescribing element. So that accounts for that big, almost 5 million spend now that's gone back to BCP Council. For all other public health services, the services are commissioned on a pan-Dorset basis. We've never tried to measure person by person the value of that spend invested, comparing Dorset Council versus BCP Council. What we tend to do from public health principles is to look at the effective and efficient commissioning of the service across the whole of the Dorset footprint. We monitor use of the service, and we try to keep an eye on whether we think that service is being used in accordance with need. So where we look through monitoring reports and we have suspicions that perhaps a service isn't being used enough, or perhaps there's not enough money in the service to cover or account for that need, we may well then have discussions about the need to put more money back in. The easiest example of that before BCP Council commissioned the whole of the drug and alcohol service was that we would routinely look at the prescribing element in BCP Council, recognising that there were more service users and the need was higher in the BCP Council area. From time to time, we would top up the prescribing service with additional money from the public health grant. So that's how we tend to look at use of the money. And I hope that sort of provided some background to the history and the way that we work the finances currently.
Okay. Thank you for that, Sam. So, Peter, something I need to know as well, actually, to explain that story. If nothing else, Peter, we've got the recording there of what Sam just did, okay, which we can replay a few times. All right.
Absolutely, and that was a really useful explanation, because some of my members might not be well, they'll start from very little knowledge, and they'll just see the figures, and they'll get a vice-like grip on the wrong end of the stick.
Okay, thank you. Graham, please.
Thank you, Mohan. And thank you, Sam, for that. And I think one of the things that we would find useful, and I dare say the BCP membership might find useful, will be some simplified briefing on what public health, on this part of the public health agenda, in terms of just a page that explains where we are. Then I'm going to put. I'm sorry, man, you haven't met Grumpy, Graham, but I find it always difficult to engage with reports that are for noting. Yeah, we can all note it, but it feels that the time to comment and the legs have gone once we're noting it. So I'm not a great lover of noting reports. I'd like to get underneath them before I have to note them, if that's fair enough. Thanks, Mohan.
Well, Graham, can I come in complete agreement with you, which is that I think given it's my first time doing this and we've got new members and so on, I think probably out of necessity we've got a few things to note here, and especially given the backdrop of the last sort of couple of years, we're sort of like resetting in a sense certain things. So I don't mind it, but just the spirit of what you're saying, I absolutely agree with. The bane of my life in my own council is reports to note, and I've said some very sharp things to various people around reports to note. And this one, my ambition, I think it was implicit in what I said and what others were saying at the start, is that we want to be, if I say deciding things, that's obviously in a context, but deciding things or strongly recommending things to, whether it be politicians, to other boards, to the ICS partnership, to the ICS board, wherever it is appropriate. But I'm very, very keen this board does not lowball anything, and we absolutely do our role to the fullest extent. I think capturing the spirit of what Cherry was saying as well, and others, is that we sort of we put ourselves out there in the fullest possible way that we can, and that's not done by noting reports. So I'm absolutely agreeing with you.
Yeah, thanks, man. I appreciate that. Getting under the weeds is one of my favourite things to do.
Gardener there. Okay, David, please, David Northover.
Thank you, Chairman. If I might just say, I think obviously the reason why this report is noted is because obviously those figures are what they are, and just obviously shows how things are being used. But rest assured, the comments that you've made today and the issues that you've raised will be minuted, so that can be taken in conjunction with the report.
Okay, is that all right then? Thank you. I've got another hand. Oh, that's David's. Okay. All right. So this was the finance report then. Steve, was there anything else from yourself on the finance report?
That was it from the finance report, Chair.
Okay, I'm not seeing any other hands. So if it's all right with everybody, let's hop on and let's go.
Can you just take my apologies, Chair? Where I'm deputising, I'm now due for other commitments, so I need to leave this meeting.
Okay, who's leaving, please?
Stephen Gorson.
Okay, Steve, thank you very much indeed, Steve. Okay.
Thank you.
All right, let's hop on then to item number 9, please, then, the business plan. Okay, and Sam, is this yourself or is it one of your team, please?
I'm going to talk to it just to set the context. It's a very short report, Chair. If the discussion then ensues, I may well bring Sarah Longden in, who's our head of business planning, as this is very much Sarah's lead role within our team. So the background and the context to the report that you have is really just to acknowledge and to seek the board's approval for a decision to pause the 21-22 business plan. And in all honesty, if I hold my hand up, we found this incredibly difficult both to put together and write in our usual way this year, partly because of ongoing responsibilities due to the COVID pandemic. So our team has been in flux as we've had to divide our capacity between covering the response to COVID. We've had quite a high degree of turnover within the public health team. Lots of people, I think, were quite tired through the pandemic response and have gone on to seek new roles. And we've also undergone a significant amount of fixed term recruitment against the Contain Outbreak Management Fund monies to make sure that we can continue to provide an effective day response team. The day response team are involved in providing the everyday response to all of the inquiries that come into the team around local outbreaks that happen, and that continues to act like a considerable drag anchor, if you like, on the work of the rest of the team. Coupled with the changes that are going on in the wider system, so not just the setting up of the integrated care system, but also some of the changes to the wider public health system, we felt that perhaps the time would be best spent, rather than paying lip service to a business plan that was perhaps incomplete, to use the time to focus on understanding what the new system was likely to expect of public health, be very, very clear on our capacity and our resources, but spend some time honing the tools that we use within the team to identify exactly what work needs to be done, to agree clear prioritisation processes that are founded on a good evidence base, and to make sure that we've got a transparent way of aligning capacity against those priorities. And that becomes a good platform to then be able to negotiate with the rest of the system where the public health resource needs to be deployed. And if I sort of talk about that in broad terms, the business plan that we started in 21-22 was really divided into 4 broad areas of work within the plan. The Public Health Board previously received a high-level version of that plan, and it divided the work up into the first category, which we call wider system work and recovery. That is all of the influencing work that the public health team do through the work of health and wellbeing boards, for example, working with both councils, to some extent linking with the transformation programmes, supporting the delivery of the council strategic plans, but also the existing plans in the integrated care system. So we ran a large programme called Prevention at Scale through the integrated care system, and that plan is still in train, even as we're starting to think about developing plans for April 2022. So that's the first bucket of work. The second area is the COVID-19 response, which I've just talked about. The third area is our public health services and delivery, which is really the focus of the Joint Public Health Board. And then the fourth large priority within the business plan was some of the work that we've been doing on our organisation. So that's the work about making sure that the public health team is fit for purpose. We've got a structure within the public health team that reflects our capacity requirements. We've managed to get through that recruitment, the redesign and the restructure successfully, and we've got the right level of resource going into some of our support services, particularly our communications, our public health intelligence function, and our business planning. So think of those as like corporate services, if you like, that support the delivery of the public health team. So that was the setup in the 21-22 business plan. But we found it difficult when we then started to get below that level of detail to understand how to prioritise our work effectively going forward, because we're continually being asked to continue to stand up in response to the changing demands around COVID. So that made it really, really difficult to plan this year, and it still makes it difficult to plan to some extent. But we're hoping that, as Peter described in his introduction, that long tail of COVID will start to wind down through the winter. We think the pressure will ease, and we're really asking for the support of the board today to come back, perhaps in February, with a final business plan that sets out the work of the 22-23 financial year in much greater detail, and that then provides the basis for the monitoring reports, which will go through the board throughout the rest of the year. So that's the background and context. I'm happy to break and take questions, but that's the decision that we're seeking from the board today.
Can I come in just first on this? Thank you, Sam. First of all, just forgive me, the 4 headings you mentioned, I was just noting them down, the 4 themes. One was sort of, I put it as the influencing, use the word influencing, sort of to the other boards, other committees and so on. And then the third heading was this board, the Public Health Board. 4th one was about team, you and your own team. What was the second one again, please?
That's the ongoing COVID-19 response. So I think the point to note is that increasingly, as the wider public health system is changing, there's a risk that we're picking up additional responsibilities around what's called health protection. So it's not just COVID-19, but it's also the response to other communicable diseases, particularly things like influenza and other vaccine preventable diseases.
Okay, so the scope's growing. Okay. Okay. I suppose one thing is that business plan. I think first of all, you're saying that what will come in February possibly is a business plan looking ahead for that fiscal year just starting. I suppose like a challenge, I know it's more work, is, I'd love a business plan to be looking further out. I do understand in this realm, business plans are typically 1 year, but I think capturing the spirit of what we've been talking about, maybe it's not the business plan I'm talking about, maybe it's another document I'm talking about, but something where, and maybe there's the level of detail here is the flex in this, but there's something there which is actually sort of laying out the picture for spuriously 3 years, for instance, and over the lifetime of sort of, it could be linked to, people here on this group and so on, and especially, for instance, with the ICS and the new person coming in there, is what kind of stall do we want to lay out for certainly more than a year? Now, this is kind of thing we can take offline, and with Peter, yourself and others, we can I'd love us to sort of plunder into this and so on. But what can you share with us now about how are we going to look forward? Because I'm really keen that we're not spending a lot of energy just focusing on the next year ahead and getting through the next year.
Yeah, I think I would tend to probably separate that into a strategy that covers perhaps a 3 to 5 year period and recognises the rest of the wider system changes. So we tried to do that in the high level business plan that came to the board at its last meeting, and it set the sort of context of what was likely to be coming down the track. But the strategy doesn't tend to change too much. Where we use our resources to influence has broadly been the same for a number of years. We see the strategic leadership piece in the system as being through health and wellbeing boards and through some of those integrated care system organisations, as well as through both councils, and that's not likely to change. So the business plan we tend to think of as our 1 year focused activity, and we would refresh that on an annual basis, and that's what the board receives the monitoring reports against. But I think we could quite easily also take a high level strategy that sets those strands out for the next three years or so. I don't think that will be difficult to do at all. It will be high level, but it sets that overall context of how we're intending to do the work.
Okay, thank you. Anyone else at all? I'm also very keen to talk more about it, but I don't want to take more board time now on it. Anything else from anyone on this? Okay, I'm not seeing any hands. Okay, fine. I know we're going to carry on this conversation. I think the subject sort of let's say an ad hoc, a very, very weighty ad hoc meeting that we can have as soon as, please, Sam, with Peter and with others as appropriate, to look into this one, and in anticipation of the ICS as well. Okay, thank you. If that's all right, everybody, I'm not seeing hands, so let's move on. That's all right. And let's come then, please, to item 10.
Chairman, if I might just quickly interject, this of course is the one item today that there is a decision being asked, if I might, just for the record, just a formal decision on the recommendation in the report.
Oh, excuse me, I actually had overlooked that. So sorry. There we are. Just 1 second.
Yes, it's. Where are we? It's effectively, if I might, the board be asked to support the decision to pause development.
Pause development of the business plan, yeah, due to delays and longer. Yeah, forgive me, sorry, David, you're quite right. Okay, so the recommendation is, let me read this out. The board is asked to support the decision to pause development of a business plan for 21-22 due to delays because of ongoing COVID-19 response work and the wider changes to the public health system and integrated care system. So we don't need all of a show of hands. If we take that as read, is there anybody who wishes to vote against or to abstain across the voting members?
Agreed.
Okay, and I'm happy with that, and I'm not seeing any hands up. So
thank you.
I think we can take that as sort of unanimous among the voting members then. Okay, I'm not hearing anything to the contrary. Okay, thank you very much. Thanks, David, for the reminder. Okay, So let's hop on to our next item. Just 1 second. Right, well, my computer does its thing. All right, item 10 then. So the JPHB Health Improvement Services Performance Monitoring Report. Who is taking this? Presumably Sam, one of your team, is it?
Yes, that's right, Chair. So I'm going to invite Sophia Callahan to go through the report, and then I'll help with any questions when we get to the discussion. Thank you.
Thank you, Sam. Thank you, Chair. The report provides an overview of the health improvement services for adults and the 0 to 19 public health nursing. It covers updates for Live Well Dorset, weight management, the community provider services, which are a range of services largely provided by GPs and pharmacy. It covers the public health nursing services as well. So would you like me to give a summary of each section, Chair, and then open up questions?
Please do.
Okay, thank you. So Live Well Dorset is, for those that don't know, is a behaviour change support for people to make lifestyle change. Obviously, there's going to be a repetitive theme throughout around changes we've made throughout the last 18 months, 2 years because of COVID. So we have to bear that in mind in terms of activity. But for Live Well Dorset, activity is increasing. It's not quite the same as pre-COVID, but we're performing very well in deprived communities, those at higher risk. Outcomes for 3 months maintain positive change, which I think is very good in terms of longer term outcomes. We have a new training offer. There are 3 stems to Live Well. We've got the coaching offer, the training offer, and we've got the community engagement and business offer. So the training offer aims to build skills and capacity for employees, for staff in terms of self-care and supporting others, but also managers to lead organisational change. The biggest thing for me in terms of well-being and health is how we change our culture and the organisations that we work and live in. Priorities are to improve uptake and strengthen engagement, and to continue engage primary care, who are under a lot of pressure with the vaccination programmes and catching up with general primary care over the last 2 years. Weight management, slight area of concern with the pandemic about how people are managing. They've been confined to their homes for 2 years, so there's a national concern of how people are in terms of managing their weight and risk. We've continued the service throughout the pandemic, which is very good. Numbers are slightly lower, but we're starting to see a shift as people start to focus on themselves and behaviour change and getting back to some sort of the new normal. In terms of the health improvement services, we've already alluded to health checks is on pause. We're looking at a review and to design a more targeted services, working with primary care and other providers in terms of high-risk communities. We're trying to find out the landscape nationally of what's happening. We're still trying to find out in terms of nationally. They're looking at what's going to be happening over the next 10 years. So we'll continue to sort of observe the national landscape, but also look at how we can engage locally, aware how we want to develop health checks moving forward. In terms of the other CHIS services, which is the Community Health Improvement Services, we've got the contraception, which is emergency hormone, and the long-acting reversible. Deliveries continued through the pandemic, albeit slightly differently, and we're starting to get back to normal, which is good. And we continue to work with providers to engage how we interface and keep providing that services for our users. Smoking cessation, again, that service continued, but we've developed a virtual as well as a face-to-face support. The activity might seem lower, but during the pandemic, we allowed services to continue, but not necessarily provide the quit data. So it'll be interesting to see the next quarter how it's developing in terms of once we start getting the quit data. But a good thing in terms of resilience of the service, Live Well Dorset stepped up and provided a smoking support service, which we now deliver alongside the other providers to actually strengthen resilience of the offer, which is really good. The supervised consumption and needle exchange has decreased. Now that's slightly due to a change in how the service has been commissioned over the last couple of years. So we'll continue to work with providers to gain a further insight into client behaviour and blocks and barriers that might influence access over the last year. We don't know if people are worried about accessing services due to COVID, or whether it's just a change in footfall and people are voting with their feet to do other things. Now, the next big section of the report is the young people services, the public health nursing. Health visiting and school nursing, as it used to be called, have a crucial role in leadership and coordination role in the Healthy Child programme, and to work with partners to deliver services. So the report outlines the KPIs, and it outlines changes made over the pandemic. So to summarise, we've built in maternal smoking cessation offer, which has been well received, which is good. Early help, we've developed pathways and evidence-based assessment tools to monitor those on a targeted intervention on specialist pathways, and these might include being ready for school, parents with mental health issues or infants with mental health issues, or vulnerable families. So there's a complex range of pathways that they're developing tools to monitor and keep an eye on, and make sure that people get the right intervention at the right time when they need it. Physical activity, we work very closely with Active Dorset to support physical activity in schools, from the Daily Mile to active travel, and there's a wealth of things going on in schools, and the report just gives an indication of that. Mental health services, we've invested in training, and health visiting, we've got a virtual interaction guidance or a VIG, which to me, reading through, sounds really good in terms of a strength-based interaction for children and parents. And some of the outcomes are sounding really positive in terms of parents reporting more confidence in ability to be a better parent. So it sounds a really good sort of strength-based way in giving parents the confidence to look at where they can improve, look at other things they can do. So I think that's a really good thing that's been developed over time with the children and young people nursing services. So I'll pause there. The board is asked to note the report, note the activity, and I'll open out for any questions at this time.
Okay,
thank you
very much. Thank you very much for that summary, Sophia. Peter.
Yeah, thank you, Sophia. Very interesting, very exciting, very heartwarming in many ways. What comms are we doing to make this more aware to the average person in the street? Because there's always a danger that we end up talking to ourselves, and I think there's a lot of good news here, and we need to, forgive me, we need to put it in relatively simple English in order to get the message out and make people feel that when we ask them to follow a course of action, it isn't in some way, you know, not the sort of thing we do here in Beer Regis or something like that. I mean, I say that as it's a slight joke, but I actually had somebody say that to me just a couple of days ago, and I think we have to try and get the message in what I would call drinking person's language, but you know, you call it what you like, but something that resonates with people. So, is there some simplified summary comms going out on this?
That's a really good question, Councillor. Sam's come online, so I don't know if you wanted to say something before I say something.
Yeah, thank you, Peter. It's probably going to be helpful if we focus on this at a future board meeting, I would say. Lucy Mears is in the meeting today, who heads up our Public Health Dorset comms team. The way that we communicate with our populations, if you like, and our service users across the different services is probably quite different depending on which service it is. So the Liverpool Dorset service spends a lot of time trying to focus their support around populations where we know the need is highest. So you'll see from some of the monitoring data, they have very much greater take-up of things like weight management services from areas that are more deprived across Dorset and BCP Council. You can see that very clearly. And we make no bones about unashamedly incentivising that. That is very much the focus of the service. For things, universal services like the Children's Public Health Service, the Health Visiting School Nursing Service that was formerly, they obviously have contact with a huge number of families in all sorts of different walks of life. So the comms that the service would do is probably slightly different to some of the Public Health Dorset comms that we would put out about those opportunities. There's the opportunity for face-to-face communication by the health visitors when they're working with families about opportunities to become more physically active or to raise and tackle things like smoking if other family members are smoking. So that would be handled by the health visitors and the service themselves. And then I guess finally, there's also a huge amount of interest in digital support, which has some huge strengths, but also some challenges. So Sophia talked about the NHS Health Checks programme, which is another service where we often do a lot of communication. We do a lot of invitation out to the general population about their cardiovascular health and their cardiovascular risk. We haven't been running that programme for a couple of years because of COVID. We weren't able to offer face-to-face risk assessments. And our main providers are GP surgeries and pharmacies who are sort of flat out delivering vaccination as well as trying to recover from COVID and get their face-to-face appointments going. But there is an opportunity to relook at that programme and to perhaps build on some of the successful work that Live Well Dorset's done through the development of their digital platform. So the Live Well Dorset service is largely telephone based, but they have a digital diary, if you like. People can sign up, they can access all 4 of those pathways using digital support. But perhaps the bit that's most interesting is something called My Live Well, which is a self-generated Facebook group of people who've been through the Live Well Dorset service. It's not really anything to do with the service at all, but it's a forum for people who've used the service and then want to offer their own peer support, having been through their sort of weight loss journey or they've become more physically active. And I think those sorts of interventions are really interesting because they don't require public money. We're using people's experiences who've been through a public service to then try and encourage ordinary people. You talked about in drinkers' language, Peter. This is very, very much about communications theory of the most trusted person to influence you in making a change to your health isn't a health professional. Often it's someone who's in your social network. So the conversation might start, can't believe you've given up smoking. You know, you've been smoking for years. How did you do that? That is a far more powerful social influence on you if you are also a smoker than a doctor in a surgery saying, don't you know smoking is bad for your health? Of course, most people know smoking is bad for their health. It doesn't mean they're going to do anything about it. So I'll invite Lucy perhaps just to make a couple of comments, but I think it would be worth maybe spending a bit of time understanding how we take different comms approaches across the different services and work with our different providers to do this in a different way.
Yeah, Lucy, please. Yeah.
Yeah, thanks, Sam. I think it's probably quite a good opportunity to have this discussion again, because as within our team in Public Health Dorset, a lot of our comms focus has been on responding to the pandemic and actually having a rethink about what we do with communications for all the other services is really important. And yeah, as Sam was saying, some of that community stuff works really well. So people sharing their own stories, case studies we try to use a lot of and make them as local as possible, and engaging with the communities as well. So we do quite a bit of work with particular areas or particular groups, so we can, which is something we've been building on throughout COVID. So we can also think about how we take that forward for some of the other services too. A lot of what we do is digital, so it's online across various different platforms, but obviously recognising that not everybody is online. So working with all of our partners as well, and it is very much a partnership approach when it comes to our communications work with both council comms teams and the NHS as well, to just make sure that we're getting all those messages out in as many places as we can, really.
Okay. Yeah, thank you. I'm really glad we're talking about this item and giving it some airtime, because I know this item is just to note the report, but please, this is really a really good board discussion on this kind of thing. You know, en route to us noting the report sort of thing, because I'll just add in this, the word I've written down here is influence, because, you know, this discussion, more than any other discussion I'm in elsewhere, is we're communicating to actually influence behaviour. This isn't just about informing people about stuff, and it's a bit like kind of a coffee table leaflet and so on, and that's all very nice sort of thing. Is actually we're seeking to influence people's behaviour in subtle and very powerful ways. And everything that you've said there, Lucy, and Sam as well, there's the whole gamut of all of that. And then very quickly, I'll run out of knowledge, and more learned people than me will know how to do this, especially when it gets into the much more sensitive areas and sort of smaller groups and down to individual level. But, you know, I absolutely agree with Peter, you know, is that it's, you know, the face-to-face and the online and so on, is that someone like me thinks online is good for awareness of something, but sometimes, I mean, who's influenced me is frankly the person next to me, whether it be sometimes a stranger, a friend, or someone I've just met or something. And I'd love to know more about what we do. We don't need to sort of take it much further here in the board. I'd love to know more about what we do here and how we can make it as powerful as it can be. And you may say, for instance, Sam, well, we're doing pretty damn good right now with the resourcing we've got, the challenges we've got, the aftermath of COVID, and so on and so forth. I think this is, you know, I said at the beginning, Lucy, when you introduce yourself, comms is so important. Comms, it's almost like it deserves an even bigger name on this. We're into a serious influencing campaign with all of this, but nicely with all our people. So anyway, you know where I'm coming from. Graham, you've got your hand up.
Thanks, Mohan. And Lucy, really interesting to hear those that stuff. And it gets me to think here that once again the local authority itself it's really poor at blowing its own trumpet. And what I would like to ask of Sam, and I don't want to put something else on his desk, but it's so important what you're putting out today. How can we take this to the wider membership in simple couple of pages of A4 form? And so my request really, Sam, is there an opportunity that we could have a quarterly briefing from Public Health Dorset that's, you know, directed at members that we can share right down to town and parish level? Not, you know, I don't want to know the nuts and bolts of it. I just want something to be able to say to our communities, do you know what, this is a flavour of what Public Health do, because I don't think it's all very well us talking about it here at high level, but to the backbencher that only turns up once in a blue moon and isn't fully engaged. And I want to engage them, and there's some really great stuff here to tell our people out there in Dorset. And so somehow I'm rambling now, so I'm going to stop. But I think you get the gist of what I'm asking.
Yeah, Sam.
Yeah, thank you. Thank you for the questions and the challenge. So I'll come back sort of fairly quickly, and I might also invite Lucy to comment on some of the things that we already do. So I think in advance of this board meeting, meeting with yourself, Mohan, and Peter, we discussed possibility of some member seminars on some of these topics. So I know that Peter came into our senior management team, and we committed to developing some of this material for use with Dorset Council members. We could very easily do something for BCP Council members as well, just on the nuts and bolts of what the Public Health team does. We already do a Public Health Dorset newsletter. I'm looking to Lucy to nod that that's still happening, even through COVID. You know, that's email subscription. It would be very easy to be able to share that through networks. You know, that's a sort of broad range of content that describes what we've been doing as a team, but it also picks up on some of those wider issues that we influence on through our work across both councils and also with communities. And then I was going to just suggest that it might be worthwhile looking at something on our behavioural insights approach through the Joint Public Health Board, because this is an area of work which we accelerated during COVID. And it's more than communications. It's the sort of looking beneath the surface at what are the behavioural targets that we're aiming to change. And then we use communications methods and a range of different techniques to try to deliver that. Lucy's just helped me deliver a presentation to regional colleagues on a regional piece of work where we did this once. We employed an academic behavioural expert from the University of West of England to do the the psychology bit, if you like, and then we turned that into a series of 4 videos based on some insight, which was undertaken by YouGov. And I think increasingly, as we start to look at the changing public health system, we may well be doing this on behalf of other councils across the region, but then being able to deliver products that can be personalised for their own communities and populations. So we are, I would say, probably ahead of the game compared with many other councils, and we would be, I think, really interested to show you some of that work. The final point I was going to make was we've run a network through COVID called Trusted Voices, which was effectively our way of trying to reach some communities that may not be on our social media channels, and to understand how some of the messaging around COVID was being understood, but also to work with them to understand how we should change what we're saying and how we're talking to perhaps try and influence some groups that were resistant to things like vaccination, for example. I would hope that one of our ambitions is to retain that network, and as COVID starts to fall away, hopefully, we can still use that network to start to talk about some other important health issues. So the network remains, they are trusted, they are often well regarded in their own communities and their own social circles, and they've stepped forward to say they're interested in helping us with some of those public health messages. So that's a powerful resource that we can continue to use.
Okay, thank you, Sam. Let me just add something quickly then before I bring in David. Just on this thing, on particularly Graham's point, is about how can we basically A, say more, but B, sort of engage the broader councillor base on this. I see a parallel here with what we do in BCP certainly, and I'm sure it's the same in Dorset Council. You know, with children's services, we get a regular sit down with them and a very stern reminder about our corporate parenting role. And so our duty, not just to know what's going on, but actually the fact that councillors have a job, and a pretty serious job, in terms of knowing what to do, knowing what to look for, knowing when to intervene appropriately, and knowing when to relay back an observation, something of concern, and something which, now I think there's a version of that here. It may not be quite of the same form, but I'm keen it goes beyond just informing councillors, because we're informed about everything under the sun in public services, whereas actually the things that actually get me moving and animated, and I'd like to see us getting others animated, is where we inform a little bit, but we say, actually, you've got a duty or responsibility or a role, and we influence people towards actually doing that, a hands-on role. And this is, for me, totally what councillors are there to do, in a sense, to be participants, to be active, to be influencing, and to be actually, making change happen, not just to be informed with things. I think, are we coming back to Lucy, or is it David? Sam, were you passing over to Lucy next, or shall I bring in David now? It's up to you.
Lucy, do you have anything you want to add, or did I?
Let's go to Lucy first then, yeah.
I think Sam covered everything mainly. Yeah, I was just going to say it is a really important point that I think somebody made earlier around communications not just being sharing information, but actually taking it to that next step of influencing and getting people to change their behaviour. And as Sam outlined, we've been doing a lot of the behavioural insights work throughout COVID and developing that as we go forward. So yeah, it's just lots of really useful pointers there for me to take away about how we can involve members going forward. So yeah, thank you for that.
That's right, but it's a very big thing, this Lucy, so please, it's not like go away and come back and present or something. It's something where I think this is an ongoing, will help as well, we'll co-create, and we'll reach the limit of our knowledge very quickly, believe me. David, please, David.
Thank you. Just a couple of quick observations. I mean, take out your point, public health really underpins all the other services and what they're trying to do, so that's a key message. And secondly, the benefits of having these virtual meetings, you see, is that the recording is available. So there might be some means to make this recording more widely available to not only members, but the general public. It is on YouTube, but to signpost them to this so they can see the type of discussion and what we're trying to do and how we're trying to do it. So that's just another thought. That's just another thing we can do, that if we were meeting face to face, we wouldn't have that opportunity.
Yeah, it is a good point, David. It's got broader applicability as well around lots of public services. Something like this edited down would be excellent. It also raises, within what you said, the idea of, for instance, YouTubes and things like that on particular small pieces, which I'm sure has probably occurred to Sam and to Lucy, but it's a good reminder of it. Okay. We're talking here about the comms thing. I'm mindful some usually very vocal people are remarkably silent in this meeting. Please do raise your hands. I'm looking keenly for all the hands. But if that's the contented quiet, that's all right. So the comms bit, we're going to come back to that. I'd like to raise another point, coming back to Sophia's run through of all the services. This is probably going to sound more harsh than it's intended to be. The services, the Live Well, the smoking cessation and so on, the weight management and the other ones, and of course very worthy on the youth side of things. That's a portfolio of services that are done, okay? Do we have the right portfolio is my fundamental question, because they sound worthy and of course there's a lot of good stuff going on. When's the last time that we checked whether or not we do have the portfolio of the most important from a sort of contemporary sense, and are they nationally prescribed or locally determined? Just say something around that, please, because if I give one angle to this, smoking, we know, has dropped considerably across the UK. Now, again, within that, I may be showing my ignorance, because we'll say, well, hang on, Mohan, the number now is still a worryingly high number, and especially, for instance, if we talk about, pregnant mothers, for instance, pregnant women, and still in that group, for instance, there may be a concern there that I'm, less cited on. But back up to the top, do we have the right portfolio? How do we know?
Well, partly they're mandated, so they're directed by government that we provide those services, and then other influences are about evidence of need and the biggest impact in terms of health gain. So, for example, you've touched on smoking and pregnant mothers, so we do a lot of work with the maternity and children and young people to really target those at most risk, who can then have the best gain from their health. Obviously, lifestyle and preventative services in terms of Live Well are the sort of backbone towards all the heart diseases, the cancers, and how we choose to make those positive lifestyle changes, and a lot of it in terms of our quality of life years. So in terms of managing long-term conditions and prevention, so we try and review our services in terms of patient use and changing all the time. We work with our providers to do that, but it is a good point. So there's a bit of a mix there, Chair, in terms of the best outcomes, what's mandated, in terms of the services we provide. I don't know if Sam wants to add anything.
Yeah, Sam, go.
Yeah, thank you, Sophia, and thank you, Chair. I think it's a really good question, and one of the challenges I've often felt was, for a long time in this country, we've had smoking cessation services, for example, which were originally started when public health teams were working within the NHS. If you looked at the reach of some of those smoking cessation programs, they were reaching 4 to 5% of smokers at their height. So in the heyday of investment back in the early 2000s, there was a lot of money going into public service that was seeing a fraction of people who smoke. And that's why in public health terms, sometimes you have to draw back and look at some of those other things that have happened in society which have contributed to big improvements in health. And the biggest thing that was a game changer for smoking was the banning of smoking in indoor public spaces. So that was an absolutely huge shift. And culturally now, if you look at the difference between the age groups, it's quite hard to find young people who smoke. There are young people who do smoke, but it is becoming increasingly rare. And smoking is now increasingly a habit of older people because of the addiction and being unable to shed the addiction to nicotine. But also, sadly, it's a habit that persists in some of the more deprived areas. So it's a timely reminder that we do have to continually review where we put public money into public health services. Are we reaching the groups that we feel we still need to reach, and having the opportunity to improve outcomes in some of those communities where we know that life expectancy is lower and healthy life expectancy is lower? continuing to provide smoking cessation support is still a good thing to do in terms of the evidence base, because the prevalence of people who smoke can be as much as 30% in those communities compared with about 12% in the rest of the population. But I think we shouldn't be complacent, and there are always opportunities to review how we use the public health grant. And one of the things that we try to bear in mind is how do we have the greatest reach and the greatest impact, but also think through things like equity. So are we making sure that the services are as easy as possible to access for the groups that most need them? But it's a really good challenge. The final point I was going to make is, as we think about the 22-23 business plan, we are again starting to think about some of the delivery of public health services. Have we got it right? What are the opportunities to do it differently? And is there an opportunity to work with different partners to deliver those? There's a huge strand of work. I noticed Pam has come back into the call. The NHS is delivering something called the Nhs Long-Term Plan, and that is looking at providing smoking cessation support and alcohol support, but from the perspective of hospital inpatients. So inpatient admissions will all receive an assessment of their smoking status. That's being accelerated over the next couple of years. So it's another way of reaching a cohort that are still smoking, where smoking is continuing to contribute to the development of early disease. So lots going on, but it's a good reminder that we need to continually refresh the way that we do things.
Okay, okay, thank you, Sam. Okay, Jane.
Yeah, I think one of the other things to bear in mind is the impact of COVID and how COVID interacts with some of these behaviours. So we know that smoking, for example, people who smoke have a bigger impact from COVID. We've also just had released figures around the National Child Measurement Programme, which show that in the last year we've seen nationally there's been a significant increase in obesity in reception and year 6 children. So and we can imagine that a similar impact has been seen in adults, sadly. So, you know, again, that will influence where we need to put our effort and our focus in the next little while, because, you know, these aren't things that are sadly going away all the time.
That's fine, thank you, Jane. All of that is fine, absolutely fine, and there's obviously more to this than I'm probably seeing at my stage. I think the quite rightly, a scrutiny of our board will be on literally, are we paying attention to the right things? And I do understand, going back, Sam, to what you were saying, this is not a sort of a black and white assessment by any stretch. There's kind of what's most obvious, and then there's the overlays of things like equity and so on and so forth across the patch. So absolutely understand, acknowledge that point as well. But I'm very keen we sort of keep this question alive, please. And I'm reassured that you are keeping it alive as well. And if I use the word dynamic, I know that we can't sort of turn on a sixpence with our priorities with these kinds of things, but we be as sort of nimble as we can be with that forward-looking view and anticipating where the best use of the money, the time, the resource, everything goes. Okay, Cherry.
Mute.
We got you now. Oh, you're on mute, Cherry.
There you go. I've done it. Sorry, it's playing up. Just when obesity was just mentioned, particularly in school children, that just led me to wonder whether or not we are we powerful enough to make effective big changes, such as linking with school children, linking in the poor diet and poor academic achievement, whether or not we could reintroduce proper school dinners that have properly nutritional food, that sort of thing, because that's where the most impact will take place longer term. But are we as a group able to influence any of a move towards things like that, or are we just sort of able to do little bits here and there with a bit of lobbying to government?
Yeah, Sam.
I'm getting all the best questions today. Thank you for that one. It's an absolutely huge issue. I think the first thing to say is there isn't a great evidence base around childhood obesity. So depending on the perspective that you take, there are lots of different ways into this problem. You may have seen the NHS announced in the past week that it's going to be investing in some weight management clinics for children. So they're going at it clinically to say we're going to commission 15 centres where you'll receive really intensive advice and support for very, very overweight children. That's one dimension. The second way into this is through universal public health services like the Children and Young People's Public Health Service. So this is health visiting, supporting families to help with the understanding of what are the best habits to try to build into family routines to make sure that children have the best possible start in life. And that starts with things like support for breastfeeding. And there's a link between breastfed children and the risk in later life of weight gain and obesity. I think with the schools, we have to be careful because the school day is only, one element of a child's life. The whole of the environment is subject to lots and lots of different influences, some of which may be able to be shaped by schools, but a lot of which aren't. So you'll have seen the government's introduced legislation around fast food advertising at particular times. They've been very concerned about the reformulation of certain foods. So at national level, there have been a number of public health interventions going on to try to take sugar out of some well-known brands. And that work goes on, fat and sugar and food reformulation. With the development of multi-academy trusts, I think our role now is much more about influencing and working with and through head teachers to identify where schools want to go further faster. And perhaps the previous model of councils having a strong role in commissioning things like school food programmes, for example, there's much more flexibility now in the market. And with the development of those trusts, they make their own business decisions. And to some extent, that ability to influence procurement may well have been a bit weakened. But I think one of the things we've noticed over the past 3 or 4 years through the Prevention at Scale programme was when we started with some what I would call organic programmes around things like interest in the Daily Mile. At first there was quite a lot of pushback from some primary schools who were saying we can't possibly fit this into the school day, we don't have an appropriate course, how would we ever sort of manage this? But we had a GP who worked with us over a 2-year period who went round literally looking for schools that were interested, and through the impact and the influence of having a few schools start the Daily Mile programme, other schools quite quickly realised that actually you can get this going. It just relies on a bit of purposefulness, if you like. I don't know the stats exactly, but I know that lots and lots of schools now are trying to build physical activity, particularly at primary level, into the daily school curriculum. So I think, again, the pendulum swung back a bit to schools recognising the really close link between activity, alertness, being a bit more vibrant in the classroom, and in time that all feeds through into better academic performance, which was driving schools very, very clearly for a long time. So it's a big area. We are very conscious that there isn't a great evidence base, but we continue to push opportunities for everyday activity and to try to get that embedded as much as possible in the school curriculum. But I think things like nutrition in schools, it's probably variable depending on the procurement and commissioning relationships and the relationships between schools under each council. But we are very active in those discussions, and I think we probably work much more closely with head teachers, I would say, now than we have in the past. And perhaps that would be another focus for something for the board on the forward plan. You could hear from Jo Wilson, who's our head of programmes, who does a lot of that work. She would have some good case studies to share, I think, around that work.
Could I come back in, please?
Yeah, please do, Chair.
Thank you. I use that as an example. The nutrition in school. It is something that I'm very keen on nutrition, particularly with my own family and my grandchildren. But there are people on organisations sitting on this board that have expertise in different areas, all relating to the good of our residents, and that starts at
before birth, really, and up until somebody dies. So, you know, there are. I'm just asking if there are areas where we know there are some. There could be some big gains. Whether we are a powerful enough board to actually affect those gains, and whether or not we should then put that in. You know, rather than sitting and talking about things, whether we should identify some really chunky, maybe seemingly unachievable, but seeing if we can actually do something to influence it. So have a bit of ambition to get stuff done, and a bit. I'm not saying we haven't, and I'm not saying we haven't had the drive, but really pushing forward to really make an impact, because I think we can if we all pull together.
What's the term Peter uses? Violent agreement. Okay, yes. Which is actually worries me a little bit as a phrase, I've got to say, but I am absolutely in agreement with it. There's no reason why this board, this is actually, if I can, this is the importance of the work linking us with the ICS partnership, the ICS board, and whoever at the HWB board and so on, so that we haven't got kind of, you know, chaos going on. But if we can sort of get that kind of sorted out between us, I'm keen that this board is ambitious as we can absolutely can be, because, you know, or else what are we here for, really? You know, just back to an early one, you know, I didn't come into politics to note reports and so on. I know we have to in certain parts of our lives, but, you know, we're here to actually improve the health of Dorset. And I'm sure, please, Sam, your team, everybody else here, this is what you have been working on very, very well, and that's what we'll continue to be working on. And we just want to make that as absolutely the story as uplifting as it can be. So I'm totally with you, Cherry, on this one. So I'm just trying to link it back to something else you were saying on this, is that the one about Sam, at the risk of sounding like a broken record on this, this is my keenness about the more than 1 year, because it did sort of, it resounded with when you said about linking with the schools and initially the resistance. And of course, that applies to anything, doesn't it? Anything new. You know, we could go through, in a 1 year business plan, 1 year of resistance. And I'm sure people don't do this, but feeling that, oh yes, it's in the PH plan for 1 year. Oh yes, resistance, then it won't appear the following year or something. And I wonder if any of that goes on. Whereas actually, if we say we're setting out a stall for 3 or 4 years on something, or again, whatever the right horizon is, there's a little bit of a statement of we mean business with this. And, you know, we're not going to go out on a whim with certain things. They're going to be things which resound, which have broad agreement and so on and so forth. But we've got to almost lay out that sort of 3 to 4 year path to show, A, we mean business, and that we're going to go through the hump of resistance to start with before we start getting the flow, the resistance and then the flow. And we're going to ride that journey with things that we think are worthwhile. Is there anything else on this from anybody else? I can't see any other hands on this. Pam, hi, do come in.
Hi, thank you. I suppose I just wanted to add to that, because I think the example, Sam, you gave was really helpful around actually one of the key enablers in this is taking the time to invest in relationships. So keeping one eye obviously on the delivery and the deliverables we're trying to achieve, but actually probably one of the most key enablers, certainly for that element of that programme, was the time taken to invest in the relationships with the schools through the GP. Thank you.
Yeah, thank Pam. You've actually reminded me of something else I'd just forgotten. Is you mentioned the head teachers, Sam, and all this takes time. Goodness knows, I've been 5 years as a counsellor. Goodness knows, I've found belatedly how long these relationships take to build up patiently. I don't know if it's a Dorset thing or not, but the head teachers as well. And earlier on, we mentioned, I think Graham was mentioning it, sort of engaging the broader counsellors, and not just for an informing, but to actually have them do a job for the greater good of public health as well. Back to, I think, if I may, you know, the Lucy on the comms side, there's something here, Sam, I'm not trying to allocate work, forgive me, but there's something here on the comms side, which is that kind of stakeholder map, even if it's just a simple hand-drawn diagram of, we've got the head teachers, got the counsellors, we've got other key groups of people who actually have got to do a job in this whole thing of public health. They're not just customers who we inform, they're people who have got to be working for the good of public health. And then the trick is, how do we get our heads around, you know, how on earth are we going to get them to do that? Okay, Sam, yes, please.
So a very quick suggestion. I think those are excellent suggestions. In February 2022, we've got an item on the agenda, which is a look at the Prevention at Scale programme, which has been running partly through the previous Integrated Care System Plan, the Sustainability and Transformation Plan for perhaps three to 4 years now. I'm looking to Jane for confirmation of when we first sort of set that up through both health and wellbeing boards. That's a really good example that reflects the time required to gain engagement around what we think is important, build the relationships, identify what we think we can make a difference on, and then start to put that influencing network together to start to move forward on a whole range of things. So Jane's going to come back to the board in February and start to share with the board the stock take that's been done around where that programme made an impact over the previous 3 or 4 years. And of course, the whole point of that is that we're looking to refresh that and to find a new place in the integrated care strategy for that prevention work to continue. So I'm hoping the board will find, there'll be lots of examples in there that exactly highlight your point, Chair, which is the amount of time it takes. You're not going to see that in a 1-year business plan, which is why it's important to have that consistent strategy. And then we can look at some of the deliverables on a year-to-year basis within that.
Okay, excellent, thank you. Yeah. Okay, good. Good discussion, everybody. Anyone else at all, especially those who've not spoken yet? So you're all okay with this? No, do come in and say your piece. Okay, I'm not seeing any other hands. Okay, but thank you for all of that, and thanks for, of course, for the work that's been done hitherto on this. None of what we said, all the challenges or anything, takes away from the fabulous work that's been done hitherto. So thank you, everyone. Okay, so I'll get back to the agenda then. And let's go to item number, by the way, to note then, by the way, so there's no particular decision on that. We note the report, and thank you all. Okay, so let's go to item number 11 then. And Sam, I think this is yourself, changes to the public health structures, which I know some of us know about, but please do share the latest with all of us.
Thank you very much, Chair. So I've got 5 or 6 slides, which I'll run through fairly quickly just at the end of the meeting, just to bring the board up to date with some of the national and regional changes to the wider public health system. And then I'm just going to finish with a bit of a discussion on how that pans out locally. So we've already recognised the potential for duplication and confusion between lots of the different boards at a local level. I'll just try to give my view of how I think we currently work across those different boards in a way that I hope the board members will find useful. But of course, we'll continue to develop the discussion. Bear with me, I'm just going to share my screen and hopefully just bring this up. You should be able to see something.
Yes, we have it.
Okay, fab. So I've called it a changing system, and it goes back to some of the comments that I made when we were talking about the business plan and why this has been quite a difficult business plan to write this year, because there have been a lot of changes, not just because of COVID. I'll start with some national reforms and policy. The first thing to note from the public health world is that Public Health England was essentially disestablished in September, October this year, and a new agency was formed called the UK Health Security Agency, which will be the primary agency responsible on a national basis for carrying out the health protection function. In fact, what they've done is they've taken the health protection parts of Public Health England and they've merged them with an outfit that was developed in response to the pandemic called the Joint Biosecurity Centre. And the whole aim and rationale of this new health security agency is to get ahead of sort of predicting when those threats might affect us on a national and international basis. It's a sort of blend of advanced cutting edge science around health protection, but also a lot of investment in data and analytics to be able to support developing and mobilising effective strategies, quicker than we did in the early stages of the pandemic. Let's just say that and leave that one there. So that's the UK Health Security Agency, but of course the rest of Public Health England, which was focused on health improvement, now moves into a new office within the Department of Health and Social Care called the Office for Health Improvement and Disparities. That's a new agency. It's under the professional leadership of the Chief Medical Officer, Chris Whitty, and he has a number of Deputy Chief Medical Officers who will be in that office. Interesting use of the term disparities. One of the things that you'll hear in the new public health landscape is there'll be some parts of government talking about disparities, Department of Health and Social Care. NHS England talk about health inequalities because that's a national priority through their priorities for the NHS. And then also we've got a new department for levelling up housing and communities, which is formerly MHCLG, which of course talks about levelling up. So we have to pick away through those different terms. They broadly mean the same thing, but be aware that those cross-government conversations about where we need to act are going on. That's the intention of trying to get some of these government departments to work more closely together, recognising that there are parts of the country that perhaps haven't been brought along as quickly as other parts. The Home Office is mentioned mainly because in public health terms, we've become a lot more aware of them in the last year because of their role in managing asylum and particularly Afghan relocation and assistance policy. More of an issue under the BCP Council area at the moment, where they are standing up a number of hotels under a contract basis with Clearwater. So we are starting to have more and more contact with representatives from the Home Office because of some of the public health issues that arise from managing those hotels. We've had a couple of outbreaks, and as you can imagine, the need to support some of the primary care services that are looking after those people, really, really important. And there are other health protection issues that come out of some of that work too. I've mentioned the Treasury as well, because one of the changes in this spending review was this commitment to a 3-year time horizon. So rather than looking at 1-year settlements, trying to give a little bit more of a longer term shape to public finances, which is really welcomed. And in Spending Review 21, there was a commitment to protect the public health grant in real terms. So there should be a small uplift to reflect inflation. But there is also additional national funding streams for some other public health issues, particularly things like breastfeeding, something called the Start for Life programme, which will come through councils, which is, people have described it as Sure Start Mark II, but it's not quite that. It's much more interest in developing family hubs and some other family interventions. But there's also a lot of national money coming out for adult weight management. And as you saw from the NHS announcements, childhood obesity too. So one of the issues for the Joint Public Health Board locally is to try and understand where those monies are landing locally. And how do we make sense of that? How do we make sure that we've got the right oversight of where the money's coming into and a good governance process for understanding how it's going to be used? So the next big change we've touched on already, which is the integrated care system changes that was set out in a command paper called Integration and Innovation. It was published, I think, in February 2021. Since then, there's been a raft of legislation and policy that's come out to local systems about how to establish integrated care systems. I'm not going to dwell on it here, but a summary is that all 42 systems in England will cease to have clinical commissioning groups from April 2022, which was formerly the organisation that commissioned NHS providers, and instead they'll become integrated care system entities. That will mean there'll be an integrated care board with a new chief executive, and that broadly will be looking after the local plan for the NHS. And then there'll be an integrated care partnership, which drives the system strategy, particularly around integration and prevention. The point of the integrated care partnership is that councils should be equal partners on that partnership. We've already started to support some of the work through both health and wellbeing boards to have development time to understand how the health and wellbeing boards could support the development of those care partnerships, and starting to think about how we influence the setup of that strategy. That's one of the ways that the Joint Public Health Board and the Public Health team can start to help the system, get the right public health priorities into that system strategy, and have our partners very, very focused on the right things. It also talked about the importance of collaboration across populations within the ICS footprint. So there's a shift away from the previous competitive commissioning models, and much more to this concept of provider collaboratives. So within a system, you might have NHS provider organisations working together to try to reduce some of those boundaries that prevent integration. So the ideal is going back to trying to follow people and patients' journeys through the system and trying to make sure that they don't encounter any adverse or unintended consequences, if you like, that are put in the way by organisations. So the whole point is to try to take down those barriers and use the resource more effectively within the system to improve outcomes. Within the ICS footprint already, we've agreed that there'll be 2 places, and those places are based around the Dorset Council and BCP Council geographies, which is very helpful. You know, they are quite different. There are similarities between the populations, but there are some differences. And of course, the biggest difference is that one is very much an urban geography, and the other is a rural geography, and that has implications for how we think about the planning and delivery of some of those health and care services. And then the final point, the document talked quite a lot about the importance of taking a population health management approach, which there's a big link across to some of the public health skills that we have in our team, which is really around the better use of data and analytics to understand population need and to translate that into clear plans for how services can improve to tackle outcomes, tackle inequalities, and make better use of resources. There's a big paper and lots of potential going forwards. The next policy I'm just going to mention is a document that came out called Build Back Better. This was the plan for health and social care that set out the new levy for health and social care, which is based around increasing contributions to national insurance. It signalled a further white paper that we're expecting on health and social care reform, specifically focusing around social care. And it trailed the importance of systems focusing on prevention. And I took that to mean that this was replacing the previous green paper that Matt Hancock, as Secretary of State, had produced on prevention. So it's a bit of a marker in the sand, if you like, that something else will come out. There isn't any detail yet, but on paragraph 32, we did pick up that it says we will consider changing the NHS Health Check programme to a national prevention service. Now that's important for the Joint Public Health Board because the NHS Health Check programme is a mandated programme that councils have to deliver from the public health grant. And that's another reason why we've paused the delivery of that programme while we work out what's going on nationally, but also start to explore how we might deliver that programme in a different way with the flexibility to be able to pick up on some of those national ambitions. We don't yet have the detail as to what they mean by national prevention service, but I think we've got a lot of learning. We've got a lot of experience in how we delivered the programme over the past 8 years or so. So we'll be looking to do a lot of engagement with local system partners about how to get a health checks programme back up and running that fits with that national strategy. So regionally, all of this will filter down into a round of regional meetings. I think the key point for me is to recognise that there'll be 3 regional organisations trying to work together around the public health system. We'll have the UK Health Security Agency, and we've still got strong links with the health protection teams. There'll be the Department of Health and Social Care and the Office for Health Improvement and Disparities at regional level. They have particular interest in the health of people in the early years. Addiction, that should say, rather than addition. It should be addiction and inclusion, healthy weight, health and work, and some prevention services. And some of those funding streams come down through the NHS England plan and start to pick up on those priorities that I've picked out in bullet point 3, which is around the long-term plan ambitions. So they set out 6 public health actions for local health and care systems, and that included smoking cessation, adult weight management, alcohol, but importantly focused through what NHS organisations can do rather than councils and the local authority public health teams. So when the Nhs Long-Term Plan talks about smoking cessation, generally they're talking about the setting up of those services to offer assessments to people who might be inpatients on hospital wards and make sure that people are offered nicotine replacement therapy as quickly as possible and some behavioural support to try and help them quit. So they're looking at the same public health issue, but through, if you like, a captive cohort. When you're admitted to hospital, there's some evidence that suggests that's a good time to raise some of these issues that might be contributing to your longer term poor health and perhaps tackle them in a different way. And then, of course, point 4, the directors of public health will also be working through that regional partnership board. That's the interface between the regional board and the local systems, then back in turn to the joint public health board. And then I've put one slide together which just tries to run through how that falls out locally in terms of the governance and the sort of make sense of some of those local changes. So the Joint Public Health Board that we're in today is effectively a shared cabinet between the two councils for decisions about how we use the public health grant. And the focus is very much at the moment on assurance, monitoring of the effective and efficient use of the grant in line with those statutory responsibilities. Of course, there's space for the board to talk about some of the wider public health issues. And I thought it's a really interesting start to the meeting today, where there does seem to be a really, really strong support for making the voice of the Joint Public Health Board heard, more loudly in some of those other places in our local system. Then got health and wellbeing boards. There are obviously 2 boards under each council. They were set up in 2013 as partnership bodies. They're not executive committees, but the purpose was to develop a joint health and wellbeing strategy in each area, broadly to promote prevention approaches and integration. And they also have the sign-off for the Better Care Fund. You've got someone's random email address in there, unfortunately, on the slide as well. Hopefully you can read that line. The one below is the Systems Partnership Board, which is where elected members, non-executives from the NHS organisations, chief executives of the main health and care organisations and the Director of Public Health come together, led by the independent chair of the Dorset ICS, to set the vision and strategy for the health and care system. That will become the Integrated Care Partnership after April 2022. So to some extent, it's been a bit of a shadow board before the formal establishment of the legal entities. Below that, you've then got an executive team, the systems leadership team, which currently comprises executives from the main health and care organisations, and that oversees performance and delivery of the NHS plans. We do have council officers that attend that on occasion, and I attend as the Director of Public Health, but I think it's fair to say that a lot of the focus has been on the NHS side of integrated care. That'll become the Integrated Care Board after April 2022, and there's a governance paper that sets out some of the changes. So it won't just be executives, there will also be space for member representation on that board as well. And then the final board I was going to mention today is the Health Protection Board, which provides system-wide assurance on the delivery of the local outbreak management plans and picks up our health protection responsibilities around COVID-19, but also increasingly some of the other communicable diseases. That used to be a health protection network, but we turned it into a board because of the legal requirement for councils to have oversight of outbreak management during COVID-19. So I've chaired that ever since June 2020. And it's been a huge multi-agency collaboration, really, to make sure that we've got the right response to the incident. Then my final slide, this is my attempt to try and make sense of it all. And it's just a suggestion, really. None of this is black and white or set in stone. But if you think of public health, we tend to work in what we would call as professionals 3 domains: health protection, health improvement in the green box, and then healthcare public health in the middle. Health protection, as we've heard, is about making sure that we've got an effective response to tackling communicable diseases. And the work that we do locally is very much through the Health Protection Board and then up into those regional groups like the South West Health Protection Network. The bit on the right, health improvement in the green box, a lot of what we talked today around health improvement services, you can think of perhaps at two levels. There's the direct work of the public health services and our delivery and our commissioning of those services. But then there's the influencing role and the strategy and leadership, where we might be working through boards or councils, or even with NHS colleagues, to influence what other organisations might be able to do around health improvement. And that's very much the work of health and wellbeing boards through the joint health and wellbeing strategies, but also the joint public health board for a slightly narrower focus on our services. And then the bit in the middle, healthcare, public health, we haven't talked a lot about that today, but it's the third leg of public health, if you like, which is our technical use of data and evidence to inform decisions about how to commission and provide effective and efficient health and care services. So an example of that would be work around things like joint strategic needs assessment to try and identify priorities. We might do specific needs assessments, looking at particular health issues affecting particular groups, and then we'd use that evidence to then inform commissioners and providers to help them identify how they can improve outcomes and make services more equitable, for example. So the kind of work in the middle segment would be through things like the population health management work of the integrated care system. It wouldn't necessarily have a formal board, but it sort of underpins the functions, if you like, that the health and care system will be thinking about when they establish the integrated care system. So it's very much a supporting function rather than a sort of work program in its own right. So hopefully that's helped to separate out the three activities. Of course, it's more complicated than that in every day, but I've done my best to try to put them in three baskets and to make the links with the boards locally. So I hope that's helpful. I'm just going to stop sharing and then I'm happy to take questions.
Thanks a lot, Sam. Just to, it's a great achievement, something like this, just to package it up and so on. And we know that sort of 100 slides could have been presented there and so on. So thank you very much indeed. I've got a few comments myself, but let me hold back. Any other comments from anyone else at all on the changes? Big changes, okay. Peter, yeah, go ahead.
I've got excuse me, I've got 3 points to make. The first is a fairly specific point, which is that Patricia Miller, as I understand it, will be the new Chief Executive of the Integrated Care Partnership. And I would suggest that we invite her to one of our meetings as soon as possible so that we can start to engage with her and she can start to engage with us. The second point is I think those number of partnerships and boards, I have to be honest, I think they demonstrated the point I made earlier, that there's quite a lot of potential for overlap or for confusion. And the third is, I think you mentioned a regional board, or did I mishear that? And if so, what does that do?
Yeah, thanks, Sam. Please, yeah, come back on this.
Thank you, Peter. Yeah, I did mention a regional partnership board. That is really a work in progress. So it's been put together because of the recognition that there's 3 organisations now nationally that have parts of the public health system: UK Health Security Agency, the Office for Health Improvement and Disparities, and NHS England. So that's the board that I will attend from time to time as a Director of Public Health in the South West, where we can come together, identify what we think is important to work on at a Southwest level, share some of the learning, but also a chance to, to push back and challenge as well. If we think things are not making sense, or if we're sensing that there's a bit too much distance or fragmentation between those 3 organisations, there's a chance for me to challenge how that's working on the ground. I don't intend to go and listen, put it that way.
Okay, thank you. All right, Karen.
Oh, thank you. Caught me unawares there. Thanks, Mohan. Sam, thanks for that presentation. That was really interesting. I was interested in this further white paper to come and the importance of prevention. And as you know, Sam, we're really into our strengths-based approach and our ABCD, certainly in BCP Council. So I wondered how much that approach is going to be embedded in the messaging that we give out from public health.
Yeah, Sam, you want to come back? Thanks.
Yeah, thanks, Karen. I think that's a really, really important point. And if you remember back in the meeting when we were talking about some of the ways that we communicate about public health services, by far the most effective way that we have acknowledged is to work with communities and people. So rather than having the Director of Public Health say, this is what you need to do to stay healthy, having someone in your network, someone in your community who is supported to be able to work with people and give those messages is far more powerful and far more effective. I'm really, really excited by the potential of some of the Vibrant Communities work, which sits under the Health and Wellbeing Board. I know it's at an early stage, but I think the amount of distance that we've travelled, I think, as councils over the past few years in recognising some of the strengths that we have in those connections with community, it's a really, really important way of being able to deliver improvements in health for us. In the Prevention at Scale programme, which we mentioned, which the board's going to hear about in February 2022, we did commission a couple of organisations to sort of do some very, very small scale work with primary care networks around this peer-led approach to supporting people to improve their health. We can walk you through some of the work that we did with an organisation called Altogether Better, which entirely fits within Cormac Russell's asset-based community development approach. So we would strongly support that approach. And I think one of the conversations we'd be keen to have is how much public health support and capacity could we be lending to each council, because they're both interested in developing strengths-based approaches. What's our role to play in supporting that, whether it's through understanding the evidence base or perhaps even supporting around some of those projects. We'd be very, very keen to be a part of that.
That's great. Mo, can I just come back with something else, which was, I think it was Peter's comment about Patricia, and I'm really, really looking forward to seeing her come along to this board and tell us about her plans, her priorities. I think she's made clear that she's very, very keen on working in partnership with local authorities, and that's really good to hear. So, but yeah, it'd be great if she could come to a future board. Thank you.
Okay, anyone else? Thanks, Karen. Is there anyone else at all? Okay, I'll just give a couple of thoughts from me. Funny enough, it's the one Karen mentioned. We had the same thing in mind. Is that there's always a danger. Yes, we've just had a big presentation on asset-based community development. So, but there was something in that, and obviously, Sam, it sounds like you're pretty familiar with it. And just if there's one thing I talk about, forgive me, everybody. Those who maybe less sort of what is this about, is there was something there about changing the orientation from it being sort of we provide services to people and therefore the people we're looking to help, they are the recipients of it, and literally that mode of thinking to something which is this is why I was banging on about the network of head teachers, network of counsellors and so on, being actually participants, and they do a job. And I think what I recall from the ABCD and Cormac's is literally thinking of all the individuals who are living with something that, hopefully they'd like to change, and thinking about how can they actually be contributors. They're not actually recipients of something, but they're actually people who've got a job to do. But probably my words, not his words. They've got a job in the whole campaign around all of this, and they've actually got something to contribute, really. And if it's almost that way around, but I'll leave it there because it's I don't want to get sort of too spiritual on us, but I think there definitely is something there in that, and we can take that further offline. The other bits is Sam, you were saying about the boards and HWB boards and so on, is that. We go even better than just inviting Patricia Miller to us and sort of, after the event, hearing about her priorities. But you know, within reason, we go as fast as we can. This is right back to the beginning of our meeting now, and what Peter was saying is that the boards of the ICS board, ICS partnership, the health and wellbeing boards, plural, this board here, plus any other key ones, is we start thinking on a bit of paper, which is what do they do? And some of this is already known, some of it is forming because of ICS just coming on the landscape now. And actually we're still not talking about this in a year's time as to what those boards are doing. As soon as we can, we've got a view that's proactive around, for the best of Dorset as a whole, what should those boards be doing? I'd love to be able to be going to Patricia Miller, actually with a point of view, respectfully, tactfully, whatever, with a point of view about here's how it might work, and then get her reaction to it. If we could do that, that'd be fabulous. Okay. Probably get knocked back, but hey, all right. And the one about the Build Back Better, I've actually not seen that report. I know I probably should have seen it. Could David, could you share that, and wherever the link is, share that to all members here? Just please read it if you can. There's obviously something very, very important in the centre of all of that. And the last thing is just on an administrative point, but I think it is a point worth making, is that this thing about, yes, we've got Deluxe, it's been called, you know, the Department for Levelling Up Communities and so on. And we've got the, of course, Department for Social Care, and obviously for health as well. There is a risk we get lost in nomenclature with across all of these boards, and I think this is kind of a semi-serious point here. So my plea, please, to officers, to all of us, is we use plain speaking and simple language, and we don't, you know, I hope this is music to officers' ears. Please don't come writing reports in 3 different versions, which is the deluxe version and the what have you, what have you. Please, reports in the most plain speaking possible. And then whenever we need to send a letter to Deluxe, so okay, it'll be in their language, and to the Department for Health, okay, it needs to be in their language, but we must start as we mean to go on with the plainest speaking in this board so that we know what we're talking about and we're not tripping over the language at every step of the way, or else it will hamstring us. And I hope that's agreed. I hope that we can agree to that around this table. Okay. Is that all right on that item? Okay, I'm not seeing any other hands. And finally, item 12 then, urgent items. Consider any items of business which the chairman has had prior notification considers to be important pursuant to section 100B, section 4, subsection B of the Local Government Act 1972, and the reason for the urgency shall be recorded in the minutes. So just to confirm that, to my knowledge, I've not received any urgent items for tabling at today's board. Unless, David, are you aware of anything?
No, Chairman, and no urgent items for consideration.
Okay, thank you. Okay, so that concludes our agenda. Is there any other business, anyone at all? I'll take that as a no. So we've come to the end of our meeting. So we've, I think we've got a date penciled in, yes. Forgive me, for February. Yes, David, just take over at this point for next meeting.
Next meeting scheduled Thursday, February the 10th, 2022, starting at 10 AM. Hopefully it will be back in person. If that's the case, I'm arranging for a room at the Civic Centre pool. It may or may not be without webcasting facilities, but we're trying to ensure that that is retained as far as practicable.
Yes, good, good.
Hopefully, you know, the benefits of virtual meetings are well known, but this may well be our last virtual meeting. Who knows?
Okay, thank you very much, David. Let me add to that. I know certainly in the room that we normally have for this, it has good video capability there. So as many as possible, please do come in person, but absolutely respected if, you know, come February still, there's a nervousness or whatever you'd wish to come in online, please do so, and that will be absolutely fine. The other thing is, again, harking back to the start of the meeting, Sam, with whoever's appropriate, Peter, myself, and whoever else we wish. I think something which is a looking forward piece, which is about things to do with forward-looking business plan and the governance model, if I can put that right, the boards, what they do and so on. Please could we as soon as we can, sort of expedite a session so that we can partly understand, Peter and myself, and then also maybe sort of give certain views about how that should be looking going forward for everyone's benefit.
Chairman, just one last thing. You'll probably see in the run-up to this meeting, I did, well, hopefully, helpfully circulate the terms of reference of this group as it stands. So give people idea what it does and how it does it, and procedures and processes and the like. Obviously, with now a new sort of membership of the board, you might want to look at that again and see what you make of it, and if there's anything you want to look at specifically.
Okay, thank you, David. I think I'd return to my previous comment, actually. I think the way to look at that is to look at that vis-a-vis the other boards, in fact, and to make sure it's congruent and as powerful as it can be. So thank you for that. Okay, good. Sam, did you want to come back in?
Yeah, thank you, Chair. Just to clarify the request for a bit of time spent on the forward plan and looking at the way that the boards work, do you want a separate development session for the Joint Public Health Board to do that, or do you want to do it in the February meeting?
I'd request to do it before the February meeting. I think, if I may, everybody, with the greatest respect, I don't think it needs to include all the board members.
Yeah, that's fine.
But if we could take it offline and start with Peter and myself, and then let's have a think about sort of what's a kind of a working group, if I may, who can think about that and then maybe formally propose it to the whole board next time. Okay.
That's great. Thank you.
Okay, good. All right, everybody, let's give you all some time back before 1 o'clock. Thanks, everyone, for your time, and have a good rest of your week and your weekend. Thank you.
Thanks very much, everyone.
Bye-bye.
Thank you, Mo. Thank you. Thank you. Very good.
I've just WhatsApped you.
Okay.
Thank you.